I welcome you all and our esteemed speaker, Dr. Adarsh Kumar, in today's session on solving oro-dental challenges in small animals. Webinar 2, Surgical Techniques for Managing Common Oro-Dental Disorders in Companion Animals. I'm Dr. Vishal Sharma, a proud veterinarian and managing director of Oriheal Lifesciences. As a practicing veterinarian myself, with two clinics in North Delhi under the name Pets Planet India Pet Clinics, I truly understand the challenges and aspirations of our community, veterinary community. It is with immense pride that I share a significant milestone with you all. Oriheal Life Sciences is now one of the India's leading and largest manufacturer of veterinary pharmaceuticals. Oriheal Life Sciences is a company built by a vet for the vets. At Oriheal, our core philosophy is simple. We exist to serve our fellow veterinarians. Every innovation, every product, and every initiative we undertake is dedicated to empowering Indian vets and elevating the standards of veterinary practice in our community. Our product range considers safety and innovations first. We offer an extensive portfolio of herbal medicines, which are India's first 100% safe, sugar-free, and free from side effects products, making them ideal for even newborn puppies and kittens. Nutraceuticals, pharmaceuticals, injections, and grooming products are meticulously formulated to enhance the well-being of pets. Considering our groundbreaking innovations, we take pride in being among the first to introduce meropenem injection for veterinary use, ferropenem tablets, alprazolam suspension, tramadol suspension, furosemide suspension, and metazepam suspension with a long list of other innovative products to Indian market. A comprehensive range of neuro, cardiac, ophthalmic, and dermatological medicines, ensuring you always have access to cutting-edge treatments. What is Buy a Vet for the Vet missions? We firmly believe that education is the backbone of progress. To strengthen the veterinary profession in India, we have built one of the largest online platforms dedicated to continuous learning. Through this initiative, we regularly host expert-led webinars on specialized yet unexplored topics like neuroscience, cardiology, ophthalmology, radiology, and many more. Because at the end of the day, knowledge is the greatest tool in saving lives. We request you to join us in this journey as veterinary practice in India is evolving and we must evolve with it. Oriheal Life Sciences is just not a company. It is a movement, it is a collective effort to uplift the small animal practice in our country. We invite you to be a part of this mission to advance veterinary education, to enhance our industry, and most importantly, to ensure a healthier future for pets we serve. Let's work together, learn together, and grow together. We need your support. Any big and small support acts as lifeline to us. Thank you so much for being here. Now, I would like to introduce Dr. Adarsh Kumar, though he doesn't need any introduction. That's a small introduction from our side. Dr. Adarsh Kumar, a distinguished professor of surgery and head of the teaching veterinary clinical complex at Veterinary College, Palampur. With an illustrious career spanning over 28 years, Dr. Kumar has made remarkable contributions to clinical teaching, research, and institutional development. His expertise has been instrumental in advancing anesthesia and critical care, diagnostic imaging, dentistry, and soft tissue surgery. His international expertise includes a tenure as a visiting professor at the University of Tripoli, Libya, where he worked in the University Equine and Companion Animal Hospital. Notably, Dr. Kumar pioneered the Admit Pin, a widely used orthopedic implant for managing long bone fractures in small animals. A fellow of the National Academy of Veterinary Science and the Indian Society for Veterinary Surgery, he has mentored 38 postgraduate students, published 155 articles, and received 43 prestigious awards for his impactful clinical research. A sought-after speaker at national and international continuing education programs, Dr. Adarsh Kumar is a visionary leader, clinician, and educator, dedicated to elevating veterinary care through innovations, education, and excellence. I know him personally. He's a very busy person, and he spared his time, valuable time for us for teaching dentistry. And I believe this is for the first time any dentistry series happening on the internet and online program as an online program. So we thank you, Dr. Adarsh Kumar, a lot. And we have this planning that as soon as you complete this series, Dr. Sab and us complete this series, we are going to organize hands-on programs with the help of Dr. Adarsh Kumar on dentistry itself. So I would request everyone to be a part of this community till the end, and definitely it will help you to upgrade your dentistry knowledge 360 degree. By 360 degree, you will learn theory and practical all here only. Dr. Saab, can we see you now?
So, thank you, Dr. Vishal, for the elaborate introduction. Although some of the people and the delegates might have attended my first webinar that was on the basic dentistry techniques, where we discussed about the basic diagnostic setup and certain therapeutic procedures. Now, my this webinar is on the surgical techniques for managing the common orodental disorders in companion animals, and the rest two would be covering the webinar 3 would be covering the exodontics, totally the tooth extraction step by step. Webinar 4 will be the oral restorative procedures, dental restorative procedures, mainly involving the endodontics, RCT and all. So I may start with the surgical techniques for managing the common orodental disorders in companion animals. You know, the oral cavity, I told you in the first webinar also that oral cavity is again a worst hit as far as the age of the animal is concerned. And as the age progresses, you find a lot of orodental conditions which remains unaddressed, and it leads to a very, very dismal life of the pets of the companion animals. Now, the first condition, which is very, very common and we normally see, is the gingival hyperplasia. As the name indicates, that this is the uncontrolled growth or hyperplastic growth of the gingiva. You can see the gum here, and you can see how much of it has proliferated. Now this kind of tissue which proliferates from the gum, eventually, if it is not treated well, you can see almost all of the teeth, they are being covered, and animal is just unable to chew and masticate. It normally starts from a very small region, and then it covers almost all the parts of the jaw, whether it is lower or the upper jaw. So it is the proliferation of the gingiva, and this is the periodontal probe. Sorry, I told you about the use of the periodontal probe to see the pockets. Now, for gingival hyperplasia, this is going beyond 7 mm. So this is a kind of a pseudo pocket actually. So what happens that this teeth is going to be eventually covered by the this hyperplastic tissue, and it will result into a severe inflammation. Now, it is not typical tumor growth, right? But it is a kind of a reactive change, which occurs because of the constant and persistent inflammation. Treatment is only and only gingivectomy. How are we going to do it? Okay, some of the causes here, like some of the predispositions, like boxer, Great Danes, bulldogs, bullies, right? And be careful about certain medications like cyclosporin you are giving, phenobarbital, amlodipine, anticonvulsants you give. These immunosuppressants can lead to gingival hyperplasia. Poor oral hygiene again is a very important contributing factor, which leads to chronic irritation and the inflammation, which results into the hyperplastic changes, and most of them, they are some idiopathic in origin also, which can lead to a hyperplasia of the gingiva. Okay, now you can see here, this is the hyperplastic tissue here. How we are going to treat it? Now, this in particular slide, can you see I'm using a lasers here, taking off the tissue. So laser in a way is very, very effective. I do a photo ablation, or you can say photo vaporization of the tissue. Now this tissue, this laser, it desiccates the tissue, it absorbs the water, and it brings about the decrease in size and almost reduce the gingival hyperplasia. So one gingival hyperplasia, the CO2 laser is very, very important, and it is very handy also. It takes almost no time to cut or to remove, excise the gingival hyperplastic tissue. You can see the small tissue which has been removed here. Okay, now can you see almost no teeth is visible? This is the right side, and this one is the left side here. So the treatment is you can remove it with the lasers, or you can directly go with the scalpel here. So here I am doing it with the scalpel. So I give incision on the mesogingival line, remove, cut all the incise and excise all the tissue which is hyperplastic, you can see. But when you have given a cut, try to undermine the mucosa. This is the alveolar mucosa here. Undermine it, and with the help of the periosteal elevator, this is a periosteal elevator I'm using it, just scoop and scrap the tissue out. Okay, leaving almost no tissue here. Right now, then what happens is that after removal of the tissue or the hyperplastic tissue from here, you are left with this alveolar mucosa. So undermine it very gently, undermine it, taking care of the vascular plexuses here, right? Properly cauterize it, mop it, undermine it. So elevate the flap, then try to bring it to the gingiva here. So I'm using here the suture, taking a bite from here. You can see I'm taking a bite. Now I will attach it to the gingiva over here. This is the final appearance. You just imagine that how bad the tissue was looking earlier, and these are the sutures which are being applied over here. So my choice is the secure krill, that is the monokrill, monofilament suture number 30, or sometime you can go for the 40 also. I prefer in very large animals, I go for 30. Okay, and always keep the knots very short. So this is the right side and this is the left side. So right side is the gingival hyperplasia, which has been treated by the scalpel blade. Here you can see this is the gingival hyperplasia treated by the lasers. Okay, then you have to recontour the attached gingiva. Okay. And this is on 25th day. Changes are still there, but still you can see a lot of improvement is there. All the teeth, they are visible, and the animal is able to, general demeanor of the animal improves. So this one is the left side. See the condition of the left side before the surgery, and this is after the surgery. Okay, so the only positive signs which you get and which you get a feedback from the client is that there is increase in the desire to devour the food. And that is also a primary objective, that a dog deserves a perfect bite. Similar is true with the felines also. You can see how much hyperplastic the gingiva here is, and you can see the islands of the hyperplastic tissue here. Again, same thing. You can use the electrosurgical. I'm not big fan of electrosurgical unit, but I use the laser gingivectomy. It gives a visible effect. So this much of the tissue, which is very, very hyperplastic, has been removed from here. And in case you find that there is a lot of distance between the alveolar mucosa, buccal mucosa with the gum, you can always go and give the suture over there. Next is the cups, very common condition known as the kissing lesions. So cups is a chronic ulcerative periodontal stomatitis. Can you see this here? This is the marked labial inflammation, with the persistent irritation. There is a formation of granuloma also. And it occurs mainly if the plaque is not being cleaned. This plaque grows up. It makes a hard tissue over the teeth, and it start rubbing the mucosa, the labial mucosa. Okay, you can see another kissing lesion over here, right, in the region of the molar. So we call them the kissing lesions. These are the ulcerations and the erosions, especially where the tissue, it contacts the teeth. So we call them cups. So see here again, I'm using the CO2 to photo vaporize the contact mucositis and the ulcerative lesions. They are being cleaned. Here also I have photo ablated the gingivitis. You can see here. So see here, this is after healing. You can see here, and this one, and after treatment, you can see how much of it is the improvement is there. This whole of the tissue, which has been removed using the laser, or you can use the scalpel also, but you can use good methods for the hemostasis. Oral bleeding does occur, but don't be afraid of the oral bleeding. It stops also. So this is the gingivoplasty. Then on examination, you find a lot of talism, and there is a grade 4 gingival inflammation. See, whole of the gingiva is inflamed here, right? So what we have done, all the inflamed gingiva has to be removed sooner or later, I tell you. Whatever you do, you give antibiotics, you give anti-inflammatories, you give immunosuppressants. In the end, you have to go for the gingivectomy or gingivoplasty. Okay, so here you can see the inflamed gingiva has been removed. The fresh tissue or the fresh mucosa is sutured, will be sutured to the gingiva here, right? Just obviating the inflamed surface here. Otherwise, inflammation is not going to subside. So this is again freshening and debridement of the infected gingival tissue using the burr. If it is a hard tissue, it's not being cured, you can go for the burr. I'm using the rugby ball burr here, right? So this hard and very stubborn gingiva, you can use the burr, you can remove the gingiva, and fresh mucosa is sutured to the gums here. So we call it as a gingivoplasty. So don't wait for the for longer period of time for the gingival inflammation to subside with the medications. If it is not at all responding, or if it reoccurs time and again, go for gingivoplasty or gingivectomy. So this is the periodontitis in felines, same condition. This is the healthy periodontium, right? And you can see here the early changes. There is the congestion which starts at the mucogingival line. You can see here, and then it advances, And this line, gingiva, inflamed gingiva, become more thicker. It starts covering the mucosal surface and it starts denuding the roots of the tooth. Here you can see the furcation, it is now visible. Now, if it is not treated well in time, it will result to advanced periodontitis. You can see furcation exposed here. So at times comes when you have to take a decision of for the exodontics or the removal. So always advisable that if you want to address the periodontitis, address it as early as possible. How they do it, if it a single tooth is available, how it is being done. See, this is a canine tooth, right? This is a canine tooth of a cat here. So root planning is ninja. Just have a look at this video. See, take a blade, incise the gingival attachment. So gingival attachment is being cleaned, then trim away that the whole of this root planning is being done. This is being removed using the burrs. Whole of this inflamed tissue is being removed, right? And the healthy flap is retracted back. Take out the debris. Take out the debris. Don't shy away and take out the debris here. So don't leave the debris. Now you can just have a look at this flap here, and then you can go and suture it. So you can see, use a periodontal probe, see the depth here. It is not going inside. That means you've done a good gingivoplasty in case of the periodontitis. And this is the final look. This is the final look after a few days, how good the teeth is looking and how bad it was earlier. Now, canine tooth resorption is very common in cats and incidence is around 30 to 60%. It is a odontoclastic destruction of the feline teeth, there is a reaction, immune reaction, and the teeth, they start being resorbed. So you have two types of feline resorptions, type 1 and type 2. Type 1 may there is no replacement by bone, and typically it is associated with the inflammation. So you find a lot of gingivostomatitis or the periodontal proliferation. Whereas if you talk of the type 2, there is the replacement of the lost root structure by bone. So you won't find the PDL. Periodontal ligament here, lamina dura आपको नहीं मिलेगा. You will won't find. So alveolar socket will have a close association with the tooth, right? And there is only kind of a local gingivitis. So addressing both type 1 and type 2, in type 1 you have to go for a complete tooth extraction, and for type 2 where the initial inflammatory reaction has subsided and tooth has now being closely associated with the alveolar bone, and it is almost merged and ossified over there. There you need the crown amputation, right? Differential diagnosis, you have to go with the caries, neoplasia, metabolic disease, and the trauma. How are you going to do it? See, now this is the probing here. The probing in the cervical defect of the mandibular canine here. Probe it, you have to see the cervical lines here. So you start from here, you can see the local proliferation or the gingival inflammation here, right? So you have to start from here, right? Start moving the periodontal probe, come forward, and both sides, the lingual as well as the labial, come forward, and you'll find a place where your periodontal probe won't move. So this is an area which has to be radiographed. Okay. What you find on the radiograph is, you can see here. Can you see this is again a gingivostomatitis, but you find the resorbing tooth here. These tooth premolars, they are under the process of resorption. So when they are under the process of resorption, we call them type 1. And you find lot of inflammation around, right? Again, this is again the resorptive area. See this tooth here. The hardly part of the tooth is visible, and this whole of the cervical area near the premolar, it is resulting into a gingival proliferation, right? Eventually, this teeth will be resorbed. Okay, now when you take the X-ray of this particular tooth here, so you find that there is, intact laminarula. The PDL is intact here. Okay, but you find, can you see this here? Or can you see this here? This is odontoclastic resorption. The tooth is in process of getting resorbed. All of the dentine and the enamel has gone. This again, the dentine enamel has gone here. Okay, I was talking about the type 1 tooth resorption. See, this is the odontoclastic resorption here. But when you closely examine this, can you see this blue arrow here? So that means the periodontal ligament is intact. That means there is no problem with the root, number one. Then again, the pulp is okay. The endodontic system, the yellow arrow, it is intact. So the main problem is in the resorption here. Now, this type 1 tooth resorption definitely has to be addressed, and that has to be addressed by the extraction of the tooth. Okay. And when you move further, this is type 2. Now, this is a tooth which has crossed the type 1 stage and has entered into a type 2. Here you won't find the root of the tooth. There is no periodontal ligament. There is no pulp cavity. Okay. So here you don't find the proper structure of the tooth. The proper root replacement has been done, has occurred. So there is a resorption here. So, and you don't find any radiographical evidence of the periodontal ligament. Now here type 2 requires the crown amputation. Okay, you don't need to address, you don't need to extract it because it is already fused. So how you do the crown amputation? So you raise the muco periosteal flap here, right? I'll tell you how to raise the muco or periosteal flap in webinar 3 when I'll be dealing with the tooth extraction here. The crown is amputated halfway with a crosscut bar and the gingiva is sutured on it. Okay, make a flap and it is sutured on it. So this is a crosscut bar which has to be used for cutting the crown. Okay, can you see this? This is the resorbing root here. It is reduced with the diamond burr, below the alveolar margin. So why below the alveolar margin? You to go a bit deep so that you can make a flap over here, right? You get enough space to again realign it or reoppose it, like it has been closed here with the help of the sutures. So this is the preoperative radiograph of the maxillary canine. So can you see here the root? You don't find the periodontal ligament here. You don't find the pulp cavity here, right? So what has to be done? This crown has to be amputated from here and close the gingiva, right? Take again the X-ray. You can see this is the root, which is almost fused with the alveolus, and you don't find the crown over here. So it is being covered. So for type 2, you require crown amputation. For type 1, you require extraction. Just look at this. Again, you can see how the tooth resorption is again seen. So something is sticking to the periodontal probe. So you have to clean it properly with the help of a burr. Can you see this odontoclastic lesion here? So that has to be amputated. As simple as that. Now, there is another condition you might have seen. Now, this is a lower jaw of the patient. And such stubborn cases comes when you find this much of an area because of the excessive talism, salivation, or because of the infection. You find that this area is inflamed. Whatever you do, you apply anything, you go for the antibiotics, you go for the immunosuppressant, it won't respond. So it occurs when the moisture, saliva, debris, it becomes trapped in the fold of the lip. So it creates an ideal environment for the growth of the bacteria, right, and yeast. So we call it as a lip fold dermatitis, right? How to address it? Now, this is a lip fold dermatitis. We have to go for the chilioplasty, right? How to do a chilioplasty? Cut the inflamed area. You have to make a defect over here. Take with the help of the VP blade or with the help of the the electrosurgical blade. You have to remove whole of the area here. So this much of the area has to be cut linearly. Yahan se and from here. Remove this. Okay. Remove this and suture it. Suture the fresh edges. Right. You can see this is the post-operative here. So once you remove the tissue, it is very hanging kind of. It gives a space for advancing the apposition. So not of a big problem, but you have to cut it and suture it. Then very common occurrence is the oronasal fistula, and it happens. I'll just give you a reference here that once the canine was extracted by in a hospital, and canine has to be extracted, and they rotated the canine, and the canine was rotated, the root rotated, and it ended up with the oronasal fistula. Okay, so the causes are the trauma, the periodontal disease, the birth defects, and the tumors. So lately, I found that with the tumors, it has become very, very common. Symptoms, you'll find a nasal discharge, and there is a food color discharge mixed with the blood, and there's a constant sneezing. Animal is in the constant discomfort. There is a recurrent nasal infections also. Okay, so open the mouth and see it. Now, this is a picture here. Can you see these are the canines here, right? These are the nares here. Okay, so most of the oronasal fistula, ONF, they occur at this site, Although even the tooth is intact, but somehow the infection finds a place from here, even the malignancy finds a place from here, and it ends up in the nasal cavity. So the blood starts coming from the mouth as well as from the nose also. This is a CT picture here. Can you see this? This is a hole which has been created here. Okay, So when you take the X-rays, you find this. This is a region which is communicating from oral cavity to the nasal cavity, right? So this is initial presentation. You can see the discharge from the nostrils. So on examination or the oral cavity, you find this much of a very big hole which has been created over here, right? And the owner was not knowing actually what is happening, but when the anesthesia was given, huge rent in the hard palate was found just beneath the tooth. This is again the oronasal fistula which has occurred and how it has been repaired. So just see, now this is the rent over here. Freshen it, clean it, right? Irrigate it, and you give incision like this. Okay, like this. Raise the flap. So you have given, this is somewhere over here is the oronasal fistula. So incision is given like this, undermine it, raise it. This alveolar and buccal mucosa, you can say jugal mucosa, is very, very loose. The only thing you have to take care is go while you are undermining it, while you're excising your flap, don't go much deeper, right? And take care of the blood vessels also. Then you advance this flap beyond the limit of the oronasal fistula and give the interrupted sutures. Okay, this is how the oronasal fistula is. Now, I'll just show you the example here. Now, this is the tissue I was talking. This is the case I was talking. See the rent here. And imagine how big flap we have raised to close this much of a rent. So it was not exactly the oronasal fistula here, but whole of this area was affected right in the median plane of the hard palate. So, dear friends, you can raise quite a big flap of the mucosa and you can suture it like this, fix it like this. Okay, so just to give you an idea that even the bigger oronasal fistulas can also be addressed by a proper flap advancement. Correct. So this is the final appearance of the oral cavity. This is again the examination of the oral cavity. Can you see the fistula here? It's a big fistula. So sometime you do the endoscopy, rhinoscopy also just to find out the opening here if you have the facility. Now this is a typical case here. Can you see a tumor over here? And when you open the mouth, you find this. You find this hole here, okay, which is communicating with the nasal cavity. And on the nose, you find a tumor. Typical condition, cytology was sent. So it revealed the TVT. That was the transmissible venereal tumor. So 3 sessions of vincristine given. Once the tumor is resolved, then the cavity, the oronasal fistula cavity also reduced and it was again refreshed, and then you can suture it. Like this is another case you can see here. So you can close it with the help of this, the flap which has been raised here. So freshen it and suture it. Next condition is the cleft palate. So can you see this cleft here? Sometimes a smaller cleft, sometimes it starts right from the pharyngeal ostium up to it reaches the point of the anterior maxilla. So you find a lot of things which are lodged inside the cavity. So you have to incise the, you have to give relaxing incisions over here. You have to incise from here, right? The palatal defect, subdivide it into, you to give the incision, subdivide the mucosa into the nasal and the palatal layers, okay? And do a very gentle undermining, okay? Then you have to close the nasal mucosa separately, okay? And now, once you've closed the nasal mucosa, this nasal, the palatal mucosa is further undermined, right? And sometimes you have to give the relaxing incisions here, most of the times rather, and then only it is being mobilized here. So can you see we are bringing this mucosa together here. So you can see whole of this has been closed here, sorry, has been closed here, and this is a rent which heals on its own. And sometimes you can go for, if you're feeling a problem that you don't want that such is visible, again you can give an incision over here, raise a flap like you've raised in the case of oronasal fistula, and fix it over the heart tablet. So in that case you even hide the relaxing incisions. So this is the follow-up after 2 weeks. Now, what happens is that in my experience, for a larger defect, sometimes you need the revision surgery also. It doesn't heal on one surgery only. Some of the tissues, they are being removed. Then again, you have to address a smaller rents separately in the revision surgery. So this is follow-up after 2 weeks. This is follow-up after 2 months. In cats, very common trauma-induced cleft palate in cats, so you have to again divide the nasal as well as the palatal layers and suture them separately. But before closure, mind it, you have to clean the cavity, you have to flush the cavity, because you just cannot imagine what has gone inside and stuck inside. It looks good from outside, but once you try to curate the cavity, you find hairs, you find seeds, you find bones, you find what not it has eaten. So this is again the incision around the cleft palate. So acquired, quite easy to heal, but with the congenital, the larger defects, the surgery becomes a little bit of cumbersome. So this is how it is being raised here. Hold with the help of forceps and try to use the periosteal elevator to raise the palatal mucosa. So use a proper cotton swabs. Can you see this? The raised, the dissection continues. You have to dissect it until these edges, they meet each other. We call it as a mucoperiosteal elevation. So this is how the final looks comes. Then the periapical, periodontal, and tooth root abscess, many names, but what happens is that, sorry, the animal comes with this much of a shape. So initially, at first instance, you will say there's some problem with the eye, actually. You start examining the eye. So most of the referred cases to us, they comes with the problem that there is some swelling and the eye has been closed and the eye is being addressed from here. But This is mostly the root or a tooth root abscess at the fourth premolar tooth, right? And this has three roots here. And etiology is the trauma from a blow to the tooth, fighting hard objects, or the bacterial infection. So this is somewhere over here. This is a carnassial tooth. There's three roots here. Somewhere over here, the tooth root abscess occurs because of the trauma. Sometimes the trauma is so hard enough that it exposes the pulp. So from pulp, the infection goes, reaches to the apex, and it results into a formation of the pus cavity here, right? So this local inflammation causes the soft tissue swelling over here, and eye is closed. And you find a swelling to an extent that that side of the eye almost appears closed, like this. So the animal keeps on scratching the nose. There's a bad breath also because of the arrested inflammation. When you open the mouth, you find some teeth is showing a streak of the blood, and animal constantly scratches the nose. When you take the X-ray, you find that there is an area of questionable viability somewhere over here with the gas formation. Okay, so you have to treat it with the antibiotics, anti-inflammatory. If RCT facility is available and there is less of the infection, we can go for the RCT endodontics. Otherwise, my preferred treatment is go for the extraction. So extraction will deal in the next webinar, how to do a extraction of a three-rooted tooth. Then a very common condition, that is the management of jaw fractures, and a lot of things have come up. I'll just try to summarize for your ease so that you start doing it in a way, or try to upgrade your skills also. So this is obvious, have a maxillary fracture or the mandibular fracture. So most of the fractures, they are mandibular fractures because mandible is movable, maxilla is fixed. Okay, so maxillary fractures, they occur normally when they were hit by a car, there's an automobile accident. But when the animal, they fight with each other, mostly it is the lower jaw which is affected, or the mandibular jaw is affected. Okay, I'll just cover from here. So this is the lower jaw here, right? And this is the upper jaw. So upper jaw is the maxillary jaw, and this one is a lower jaw, sorry, the mandibular jaw. Okay. Now, fractures can be of many types. It can be a transverse fracture like this, like this, like this. It can be oblique fracture with the obliquity like this, or this. So the most preferred technique of fixing the jaw is the wiring. Okay. Now, but when you want to address the jaw, okay, there's a ET inside. So when you fix the jaw, you always have to look for the occlusal relationships. The Caesar bite should come. But once the endotracheal tube is inside, you just cannot close the jaws. So you won't be able that after fixation, whether the occlusal relationship has been maintained or not. So in that case, don't put the ET from the mouth. So you have to insert the finger inside the labia, feel here, right? We call it as a pharyngostomy incision. Feel here. From this hole, the endotracheal tube is taken out so that the rest of the mouth remains open without any hindrance, and you can see the occlusal relationships once you fix the jaw, or once you treat the jaw fracture. That is very important. Otherwise, if the occlusal relationship is not being maintained, you always find some kind of disfigurement, some kind of occlusion in the oral cavity. So remember that whenever you are dealing with the jaw fractures, try to do the endotracheal tube by the pharyngostomy incisions. The first thing is the tape muscle for the maxillofacial stabilization. So this is how the tape is being applied. You want to refer, there's a small fracture. It can heal with the a tape muzzle, or you want to refer it, put a tape muzzle, right? But remember that whenever you want to put a tape muzzle, always make sure that the animal is not breathing from the mouth. If the animal is breathing from the mouth, right, then don't put a tape muzzle. Just close the jaw for a little bit of time. See whether the animal is breathing properly or not. If the animal is feeling problem breathing, don't put a tape muzzle. So for cats, this is the muzzle coaptation, how it is being done, or you can use the adhesive creep bandage. Now, this is how it is being used for stabilization the mandibular fractures. So very common fracture, you can see this is the separation of the mandibular symphysis. You can see this radiolucent line here. Okay. So how it is being fixed? We go for the button stabilization. Look at this video. I've taken it from the modern. Right? So this is how, So what happens is that from the soft tissue here on the upper jaw, a suture is taken. It is, from a button, it goes into the lower. From there, we again put a button, bring it back and tie it over here, leaving certain, little space in the mouth cavity to remain open so that you can feed. But this stabilizes the small cats, especially the small cat. It stabilizes. Animal can open the mouth, but these buttons passing through the lower lip and the upper lip, they are stabilizing the jaw. So, good method to treat. And when you want to do a surgical approach, you have to bring the animal into the dorsal recumbency and you have to give the incision on the ventral side. And from the ventral side, you have to approach the jaw here. Okay. Now, this is the unilateral. You can see the fracture line over here, oblique fracture. It is being managed with the help of the wires here. So you can take the wires out from here and you can suture. This is the incisional approach, right? Or sometime now, this is again a very bad fracture. You can see this fracture has almost, has rendered the rostral mandible almost non-functional. Okay, so this is how you're going to treat the symphysis. The symphysis is being separate here. Okay, this is again the initial presentation of the case. This is the preoperative radiograph. So you take the, you can do it with the help of a 18 or 16 gauge needle also, but sometime passing through the bone, it becomes a cumbersome job. So I always try and use the, what do you call, the drill machines here, the drill bits here, create a hole, right? And on the lower side, take these wires out and you can tighten it from there. This is known as interfragmentary wiring. Okay, this is how the jaw is being tightened over there. This is, but always remember that whenever there is a jaw fracture, the jaw fractures, but at the same time, there is a breakage of the oral mucosa also. So whenever you have fixed a jaw, you've fixed it with a wire or anything, please suture the oral mucosa. Right? Sometimes you have to undermine it, sometimes you have to harvest the flap, but try to suture it. It will aid in early healing. Otherwise, if some food stuff or anything going to stuck over there, it will delay the healing. So the another method which is now being popularized is the preparation of the teeth for composite application. Right. So we go for the scaling here, the acid etch it, and this is the air drying of the corneal surface, right? Then I'm using the ProTemp. This is the acrylic here. This is the acrylic here. How it is to be applied? Just look at this video. So this is the splint. I've used a wire over here, but I've hidden the wire not in the acrylic splint. So you can, in very small dogs or cats, you can simply use only the acrylic ProTemp, or you can reinforce the wire fixation along with the acrylic or fiber, this ProTemp application. So this becomes very hard. After 2 to 3 weeks, 3 to 4 weeks, you can remove it. It becomes very harder. So just see here. This looks like this, the caudal teeth, and this is the anterior splint. Whole of the tooth, they are covered. So this is the wire, and this is the ProTemp here. Additional stabilization is being provided. And just look at this video, how tough it becomes sometime to remove the composite. The ProTemp. So I'm using the burr to take the splint off. Right? So you can crack it with the ronger also. So this is the final appearance after the removal of not the composite, but the ProTemp, right? And this is the final radiograph. The jaw is in a perfect union here. So this is the interdental wiring. Sometime you can take an endotracheal tube and put the fiber, the ProTemp inside, and put it into the lower canines, fix it on the upper jaw. This will fix the jaws. This will fix the jaw. We call it as the fixation of the jaw using fiber or acrylic, sorry, not fiber, acrylic or the ProTemp. So this is interdental fixation. So this is the acid etching we are doing, and then it is filled with this is a cut endotracheal tube. You pour the ProTemp inside, pour it in the other, fix it on the teeth, and from the above, you can go for the application or the reinforcement of the ProTemp, right? So this is the maxillomandibular composite splint. And these are the intel-arcade wire splints. You can see this from here, a loop is being made, and here also the loop is being applied. Here, 8-figure root. So just to give a stabilization. Along with that, since wires, they become visible. Now it has almost become norm in our institute that even if we fix the wires, we try to hide the wires with the help of the ProTemp. Okay. So this ProTemp, although not very costly, but it assures that there is no injury with the wires to surrounding tissue, and it also ensures the proper fixation of the jaw with the help of a acrylic splint. So this is the picture post-operative. So next is the management of the oral neoplasia. So oral neoplasia is a very huge topic. So I'll be just covering a very small of it, giving you a bit of clues. So you have two kinds of neoplasias, the benign neoplasias and the malignant neoplasias. Benign, as far as the oral neoplasm are concerned, they will not invade the bones. If the bone is not being invaded, we'll say that it should be benign. If it is bone is invaded, surrounding tissue is invaded, it is the malignant oral neoplasm. So when the case of oral neoplasia comes, you have to rule out osteomyelitis, periodontal disease, endodontic disease, or the metabolic disease. Okay. Now, what are the benign tumors? These are the benign tumors, or you can say non-cancerous masses. So AA, acanthomatous ameloblastoma, odontogenic fibroma, or gingival hyperplasia. It is again a non-cancerous gingival hyperplasia I've discussed earlier. Now, there was a term called epulis. Epulis is any mass on the gum, right? It may encompass benign or malignant tumors. So epulis is not like benign. Somebody is asking, or it is benign. It is any kind of the mass which has its origin from the gum, right? But normally we refer epulis to be a benign mass, correct? Malignant tumors are the melanomas, squamous cell carcinomas, SCC, fibroma, or osteosarcoma. Now, when you address the oral tumors, you try to group them according to staging. So if tumor is less than 2 centimeter dia, it is stage 1, 2 to 4, 2. If the tumor is greater than 4 centimeter or ipsilateral lymph node metastasis is also there, bone involvement is there on the X-ray, it is stage 3. If tumor is of any diameter and you find that the contralateral lymph node is, is metastasized, and when you take the aspirate, you find the cells, or there is a distant metastasis into lungs, let's say, then it is stage 4. Very simple classification or a grouping of the oral neoplasias. We call it as a TNM staging of the oral tumors in dogs. So when you talk of the incidence, malignant melanoma 31 to 42%, SCC 17 to 25%, FSA 75 to 25%, 0.5 to 25%, osteosarcoma 16 to 18%. AA is benign but locally invasive, and other tumors are the osteosarcoma, lymphoma, or the mast cell tumors. Some of the feline fundamentals should always be remembering that benign tumors are extremely rare in cats. They are mostly the benign malignant tumors. Therefore, any tumor in the feline oral cavity, you have to counsel the cat owner. Counsel the cat owner means that you have to prepare the owner for the biopsy and excision of the masses and telling about the nature and the incidence of the tumors normally cat they have and what can be the possible prognosis of the patient. Okay. Now, when the tumors are there, especially the malignant tumors are there, you go for the mandibulectomies. There are many kind of the mandibulectomies. So this is the rostral hemimandibulectomy. This much of area is being removed. This is rostral bilateral mandibulectomy. Here, this much of area is involved. This is central hemimandibulectomy. So this is the caudal hemimandibulectomy. Okay, so this is total, one side of the jaw is being removed, hemimandibulectomy. This is 3/4 mandibulectomy. Okay, you are lucky enough that if rostral hemimandibulectomy comes, as we involve more of the jaw, more of the area of the jaw, the surgery becomes tedious and difficult also. Now, this is a case where the mandibulectomy, I'll show you here. So can you see the tumor is somewhere over here? So we are going for the mandibular rostral mandibulectomy. This is a saw which has been applied. So this much of the tissue has been removed and you raise the flap over here. This is how it has to be removed. Okay. This is again. So you have to close the surface. Squamous cell carcinoma in 60 to 80% cats, right? It is, the incidence is like that. So it looks like this. And the treatment is nothing but the mandibulectomy. This is again case 1. You can see the rostral mandible is available. This is nose. This is the rostral mandible which is engaged. So we are going for the excision of growth. First of all, with the help of the periostal elevator, we are removing the visible tissue with the naked eye. And then this much of the jaw has to be removed with the help of a bone saw. So you can see this is the wide margin resection of the, the jaw. We call it as a rostral mandibulectomy. And this is the flap formation. You can see how finely the flap looks like 2 weeks post-operatively. So normally what happens that there is a big question on the how visible, appealing the animal should or would look after the mandibulectomy is whether the animal is able to eat properly, drink properly, or even the look properly. But remember, if it is a rostral mandibulectomy, it works, right? If it is a hemimandibulectomy or that to a central hemimandibulectomy, it works. But once there is a hemi, or if it is a two-third hemimandibulectomy, there are certain crippling issues which are always there and has to be explained to the owners. This is the case too. Can you see the growth here, right? So very locally invasive growth. So this has been removed, right? It has been removed. The bone, the rostral bone is removed. It is sutured, and this is the final look, after a week. This is again the tooth here. You have to go for again. So never shy away for mandibulectomies. If you don't do it, they will reappear. So this is after 5 months, there is no reoccurrence. And you can see the animal is now adapted to the incisors are removed. You can see the canines here. The rostral mandible is gone, but still animal is managing with the remaining jaw. Again, same, it won't take much of time here. So I'll just move forward. This is a small initial presentation. You to remove it. Periosteal elevator take and remove the growth. Use some photoablation with the help of laser, even the electro excision, right? Remove the tooth. Any tooth which is there in the growth or within the mass has to be removed, right? And then you have to take a round burr, right? And freshen the tissue, freshen the bone, and raise the flap like this. You can see this is the rostral mandibulectomy. So the rostral incisors, they are gone, and there is a suturing over here. This is the look. There's no growth. Likewise, similar case. So this is the animal. This is a quite extensive one. So the animal is in the dorsal recumbency. The lower jaw flap is being raised. Whole of the jaw is being exposed, and you can see we are applying the bone saw here to cut this much of a tissue. So the tissue is being removed. I'll just show you. See here the final look. These are the tissue which are being removed, and you can see here half of the mandible has been removed, and the flap has been raised and sutured. So this is the initial presentation, a very small growth here. So you can see here, you can remove it. See here. So I'm removing it with the help of a CO2 laser. So for small growths, CO2 laser becomes very, very handy, and see the post-operative appearance. This much of a tissue is removed, and you don't even find the scar, a proper scar over here. So that is the beauty of the photovaporization which the CO2 creates on the site of the tumor. Now this is a AA, acanthomatous ameloblastoma. I'm injecting the bleomycin intralesionally here. Okay, so this is the intralesional. You have to be very careful. It should this chemotherapeutic drug should not come out or leak from there. So that's why another person is holding a gauge, and some 0.3 to 0.5 ml of the this bleomycin is injected into the locally invasive AA, and the dose is this, but always make it sure that whenever you are injecting the intralesional drugs, do wear a mask, gloves, and take care of the hygiene. Okay. These are the glossectomies. I won't cover it much, but you find tumors over here, you have to remove it. This is the wedge glossectomy. Remove it, and then suture it. Sometimes a small tumor is there. This is again a small tumor. You to give a wide margin resection and again suture it. Transverse glossectomy. You have a longitudinal glossectomy like this. You have to give a longitudinal incisions, remove the tissue and suture it. some of the common chemotherapy protocols for the canine tumors. I have given the type of the tumor, the drug to be used, and the dosages for your running reference. So I won't go much into the detail. Last condition is the dentigerous cyst. What's the time? Okay. So dentigerous cyst is the cyst which arises from the animal, right? And mostly it has the impacted tooth. So what happens is that these animals, they come with a swelling over here. So normally what you do is you palpate to find some fluid is there. So normally what we are doing is we take the fluid, aspirate the fluid out, the swelling subsides. But next day animal will again be reported that the swelling has again reappeared. The fluid has again come. So when you take the X-ray, you find this impacted tooth over here, along with this cystic growth here, like this. This is the cyst here. This is fluid, and this is the impacted tooth. Now, if you aspirate it, it will again reoccur. You have to extract this tooth from here, right? You have to freshen the edges of the cyst and close it with the help of a suture, like it has been done over here. Okay. Like it has been done over here. Okay. You have to give the incision, take it out, then only it will subside. Otherwise, it will keep on reoccurring. So this is again a radicular cyst. When the embryonic tissue remains, you can see here. This is the radicular cyst, right? So again, incise it, destroy its secretory surface, and suture it. Fine. These are certain conditions which are very common. So I've tried to touch not very advanced, although conditions are very, very, it has a long list, but the mainly conditions which we normally encounter in the field, they are there. So thank you from my side.
Sir,
I hope I didn't go overboard. The time is,
I think very much within the time. And we request everyone to post their queries in chat box only.
There is a question here. Sir, there was treatment of oral papilloma. Yeah, oral papilloma is, you see, a very common condition, a very good question. I like that. So oral papilloma tests, it occurs, you can go for the autohemotherapy. Take a blood, right? 2 ml blood, inject it at 2 sites. If autohemotherapy is not working, then you can go for the removal with the, or you can scrap it with the BP blade, or you can scrap it with the help of a laser also. But autohemotherapy, it does works. Okay. Some people go for the homeopathy also, it also works. So there was a case recently where a dog of 5 years age had overgrown canines. Yeah, very good question. Overgrown canines causing the kissing lesions on the labial mucosa. So we go for the deviation of, there are two methods to, treat this. One is the overgrown tooth is being directed with the help of the composite formation. You apply the composite. I'll tell you in the oral dental restorative procedures how to apply the composite over there. Or you can go for the crown shortening. And after crown shortening, you can apply the composite over there to prevent the pulp from being infected. Correct? Can you tell the name of this? Is Pro Temp. This range is costing somewhere around, this is, I think, maybe 100 or 150 ml, and it is costing around some 5,000 to 6,000 rupees, very much available on the dental card. So you can buy it. So it has the applicators. When I will deal with the fourth or fifth webinar, I'll tell you how to, third webinar, then I'll tell you how to apply it. So crown shortening is one of the thing you can always take, and you can do the carving of the elongated tooth also. Do we need to put bone wax after? Yes, extraction, you have to sometime put the bone wax. I will deal in the webinar 3 with the extractions, So bone wax, there are a lot of things you can do, the grafting also. Do you suggest NG tubes for enteral nutrition post the surgical procedures? Well, only in one condition, that is, which is very dicey, that is the cleft palate. In case of cleft palate, there is likely chances of lodging or disrupting the suture line. So I always prefer that there should be a nasogastric feeding when especially there is a cleft palate. Or even the oronasal mucosa. It depends upon the age of the animal also. So the level of activity also. If the animal is comfortable, you can easily put the NG tubes. While pointing out on imagings, you can use red color, etc., instead of using white cursor to get. Oh, thank you, Abdullah. Redness, pain, and no swelling in the cheek mucosa subsides with antibiotic, but reoccurring. This is the gingivitis, right? And this kind of gingivitis normally reoccurs when there is an autoimmune disease. Here, try the immunosuppressants. All right. So I think those were the questions.
So now, sir, on behalf of the veterinarians who attended the session and the entire team of Oriheal Lifesciences, we sincerely thank you for taking the time to share your knowledge in webinar on surgical techniques for managing common oro-dental disorders in companion animals under the series Solving Oro-Dental Challenges in Small Animals. This session was extremely informative and practical, and it helped simplify the many key aspects of oro-dental surgeries for our attending vets. The way you explained the technique were not very clear, was not only clear, but also very relevant for daily clinical practice. We truly appreciate your support in contributing to veterinary education, and thank you for being a part of this initiative powered by Oriheal Medicine Range for oro-dental cases. Looking forward for many more meaningful sessions. Thank you so much.
Thank you, Dr. Vishal. Thank you. Thank you so much. And thank you, everyone, those who attended. I'm always available either through Dr. Vishal or you can directly contact me also.
Sir, you are always available to everyone. I know that. Thank you so much, sir.
Thank you so much. Thank you.
Yes. Have a wonderful evening, sir.